My name is Roberto Vargas. I'm an internal medicine physician and health services researcher and policy analyst. I serve as Assistant Dean for Health Policy here at Charles R. Drew University of Medicine and Science, and I also direct the Policy Core in our Urban Health Institute. My area of expertise and research spans health services, which includes looking at population health, how they receive health care, how they utilize health care, and how those things intersect, with some focus on quality of care and development and testing of interventions to reduce health disparities and improve health equity.
I'm Rajan Singh. I'm a faculty member here since last 16, 17 years. So I'm in the division of endocrinology and metabolism, and my primary interest is to understand at a molecular level how this body composition, mostly the muscle and fat, is regulated at a molecular level. So when I came here, I started my research trying to, especially in the field of aging, trying to understand the molecular targets and the key determinants which regulate these two important factors in the body. And since then, I have been doing my research, and now I have hit upon a protein which is called follistatin. We identified this protein a long time before as a direct target of androgen signaling. And since then, I have engaged and taken this work further. And now I'm specifically interested in trying to understand how follistatin and its newly identified role in the regulation of brown adipose metabolism could be used, and the research findings could be translated at a clinical level so that it can benefit our community and our country as a whole.
Knowing just a little bit about the basic science aspect of it and the relationship to obesity and health, we are in South Los Angeles. When we look at health disparities, specifically in health outcomes, why people in our settings often die from diseases that are treatable and preventable, one of the key mediators of those worse outcomes is obesity. And here at Charles Drew, we really understand this connection between community and research as a unidirectional, I should say as a bidirectional relationship, although people tend to think of it as unidirectional. So my question for you is not so much about how that basic science will actually lead to the obesity-related discoveries, but because we understand it as a problem, what are some of the things that you need to get to that next step of discovery or evidence to really say that you found this relationship, and now we need to get that to the level of a medication, an intervention, or a more solid level of evidence? What things can we bring to your activities, your knowledge, your experience from a community level, from clinicians who are involved in this, as well as those of us who are involved in health policy and decision making, to help you really get to those next steps?
So we all know that obesity, by definition, is nothing but a disbalance between how much energy we gain and how much we expend. If we gain too much and don't burn, this excess energy remains there, and that disturbs the systemic energy balance, which is the key culprit of most of this metabolic disease. So these findings which I have in the lab, I do have these findings from using in the lab setting, mostly from the cell culture experiments. And now I have transgenic mouse models where these mice are overexpressing more. So I'm trying to analyze and take this knowledge further to establish that in the preclinical mouse models. So those things are important before we move into the real life scenario, because these things are required to provide a proof of concept. So as I make progress in this direction, I would like to engage into this community research and talk to the experts in the field who have been engaged doing clinical research to see if these basic findings in the lab, which we all learn from bench to outside, So we want to test in those systems that yes, if this finding holds true, and if that, I'm pretty confident that it will. From there, then we would like to build up on these findings so that we can go ahead, collect clinical samples, clinical data, and try to see what kind of correlations they have. What happens when certain patients on the metabolic disease, they are taking certain kind of drugs, which is helping them improve. So what happens to this follistatin level? So this kind of correlation studies as to how this overall levels of follistatin and their interrelated cellular targets or partners, they are influenced during the progression of the disease and during certain interventions, so that we can identify at a molecular level that what sort of proteins could be targeted and are should be deemed as from the perspective of therapeutic potential.
So, if I understand correctly, that next step, that leap from what you've identified in these mouse models, being able to look at some variations in human populations,
Exactly.
to look at whether or not the follistatin levels differ in different cohorts,
Right.
looking at patients who may have either different levels of obesity or not, and then measuring those differences will give you more information.
Right.
And
So that will kind of give me proof of validation of the findings, proof my hypothesis, because all these findings are coming from the preclinical models using mouse model and starting from the in vitro studies.
Yeah,
So this needs to be before we go there, and I'm right here doing most of these experiments using my several different kind of transgenic mouse models and different cellular systems.
I definitely feel as though, I think that there's, I guess, maybe 2 or 3 thoughts I have on that. And one is that, really explaining to our community, that we have research taking place here that is giving, the world information about this obesity epidemic that's new. I think we need to, that our children and the community need to know about that, just to know what's happening here. And then I think from an operations perspective, if that getting, people to come in and provide clinical data about their weight, their exercise, as well as, blood samples, would help you really further your research. We have the capacity to do that.
Yeah.
And we can definitely engage the community to say that, these are next steps in research that we can support our institution by doing, by getting people to enroll. And I think thirdly is, the technical aspects of things like the RTURN Center, which is the Research Centers for Minority Institutions, or Translational Research Network, could actually expand that request to many of the historically black colleges and universities and minority-serving institutions. Those would be opportunities to begin to advance your research, that we actually have the capacity here to do. We have some opportunities, I think, even short-term, to maybe have you come talk to some of our community academic councils. I would love to bring you in to talk to that group, because I think that, oftentimes, people will look at the public health problem and disparities problem, and not make that connection to what's happening in the lab and how that either can help us better understand the environment-gene interaction that results in disease, but also may develop a therapy that can solve the problem, so that if it does develop into a product that can address this, I think, I don't know, I'd like to, maybe when we have that conversation with community members, we can find out what their
I'd be excited.
Because I feel like it'll give people some hope to say, wow, that, these guys are working on this, and, that may actually help solve this problem. Maybe it might even spark, a new idea or hypothesis for you, but I think that getting some of that bi-directional exchange
glad to learn
would be great. And so,
explore those possible avenues.
all right.
I would like to learn from you, how you engage in different kind of community academic research partnerships and investigating, navigating patients and recruitment of this group, which is very critical to the success of any translational research, because I understand that whatever we do on the bench, someday we'll have to get out of bench and explore and assess its importance in in the community.
Yeah. So I think, this aspect of the community partnered research that I've written about and the patient navigation programs that we've done in some of our research really wasn't my start as a researcher, but it actually was my start in terms of going into a research career. So I started off as a primary care doc in Harlem, taking care of patients without any population health science training. And one of the biggest challenges that we had in primary care in that setting, even though we're in New York City, and there were tons of very large medical centers all around us, if we took care of somebody who was poor, who had Medicaid, which is kind of the New York equivalent of Medi-Cal, or if they didn't have insurance, if you were the primary care person, you talked to that person, you got their story, you figured out what was wrong. If they had to get specialty care and they couldn't afford it, or they had a health insurance that most of the practices around you didn't take, it would either take a long time for them to get care, or sometimes they just wouldn't get it. And coming out of a good training program and knowing what people are supposed to get as a primary care doctor, and then sitting there day after day and watching people come to you with diseases that we've known how to treat for 20, 30 years, and that there's centers 10 blocks away that have the full capacity to do it, but unless you write that check yourself, that person's not going to get it. And then you got to tell that person that, look them in the face and say, my knowledge has taught me that as a physician, this is what should happen for you. But you come to me in a setting for which you can't afford this, or you don't have this type of insurance. And so as an individual who's responsible for your care, I have to watch you, die or suffer or not get what you're supposed to get. And then you got your 15 minutes is up and you close that door. And when you walk it was heartbreaking. So, doing that, I realized that the challenges that were going to make me feel good about what I chose to do in terms of helping people were not going to be able to be addressed solely by my ability to sit down with that person, hear their story, and bring together the clinical information to say, okay, this is the condition, and here's what you got to do, because there were all these other things. The patient navigation program was something that, when I was in Harlem practicing, the one condition for which I didn't have that horrible feeling when I talked to somebody who was poor, and they had a condition that was going to go beyond what you could do for them as a primary care doctor, was breast cancer. So that I had started working at a hospital at a time in which a physician named Harold Freeman became the CEO, and he created a program at Harlem Hospital and brought it to that community hospital, for which he called it patient navigation. And it was basically hiring somebody from the community who would develop a relationship with somebody at the time that they got diagnosed with breast cancer, and made sure that they got through all the steps of care. And it was just that simple. He just hired somebody, just did it. It wasn't a trial, it wasn't, didn't do a cost effectiveness study, he just did it.
And these are the fundamental things which kind of incorporates our community from the grassroots level, that without any discrimination and without having the socio-economic barrier, because getting yourself the coverage from insurance is like a big challenge, even for like a general population. So it's not very hard to understand that what happens to the community people who do not have this health insurance, who are not covered, who takes care of them? Yeah. So they still are the partners, they still belong to the community.
When I got here, and I started at UCLA and Rand, Charles Drew and UCLA were the one institution in the country when I was looking for a job that had this relationship, that they talked about academic and community partnerships. So I came here to learn about that. It's allowed this space and this dialogue for me as a clinician to talk to communities about the downstream effects of what they're seeing and how that's relating to what we see in terms of population health. And I think that now that these mechanisms are really entrenched, it's also given us opportunity to sit down with folks like yourself, right? Which is to say, can the community learn what's going on in the lab so that we may get them to engage in these studies more without fear?
It's very important for health, especially the health disparity research, without this proper partnership with the community. So there has to be like a very balanced academic and community partnership. And the whole goal should be how to reduce the health disparities. So what is there in the community which we can bring and ask the academicians that what needs to be done, then what the appropriate timing and the procedure to move forward.
What is it that we can learn from these relationships with people who are dealing with the problems real time
Yeah.
to help us solve those, and then bring the whole of what we know from our experiences, from understanding the basic sciences and the clinical medicine to solving that.
We cannot go further as a country if we do not incorporate people from every corner.
Yeah,
This kind of research which you are doing and engaging community with the academic and basic science and translational research is very, very important.
Yeah,
And
I
I'm
hope so.
glad to be sitting here and talking to you and
Yeah.
getting excited with all the opportunities
Yeah.
and possibilities.
And I hope so.
I hope to continue this discussion and meetings with the group.
No, it's been a pleasure.